So good morning, everybody. Welcome to Building Clinical Informatics Learning Community, Session 1, the Intentional Virtual Care of Self-Measured Blood Pressure Monitoring, SMBP, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleague, Meg Meter, the Director of Clinical Integration and Education. Before we get started, I would like to review a few housekeeping announcements. You have physically joined this event by either calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 45 minutes, including introductions, presentations, and of course, Q&A. Again, the duration of this event is approximately 45 minutes. The Q&A box is located in the lower right-hand side of your computer screen. Feel free to type your questions into this box at any time. Simply open the panel if it's not open already on your computer screen. Type your questions. Make sure you select to all panelists and hit submit. We will be answering these questions at the end of today's session. If for some reason we cannot answer your question in the time allotted or we need additional resources, we will make an attempt after the event has been completed. Friendly reminders that today's event is being recorded. All attendee lines have been muted and will be muted for the duration of this event. The Q&A box is located in the lower right-hand side of your computer screen. Simply type your comments, questions, or concerns into this box at any time. If for some reason we cannot answer your questions in the time allotted or we need additional resources, we'll make an attempt after the event is completed or place your questions into a robust FAQ document. And last but not least, you'll be presented with a brief 4-question survey after this event is completed. This survey lets us know how we did, how valuable this event was to you, and directly informs us of future trainings and technical assistance. But I would like to move on. I'm going to turn things over to Meg, who will be introducing today's speakers and setting the stage for you. Meg, the floor is yours.
All right, thank you, Liz. So good morning, everybody, and welcome, as Liz said, to our first CMIO learning session on intentional virtual care, self-measured blood pressure monitoring. We trust this is a timely topic for most of you. I want to quickly introduce our speakers. So first we'll be hearing from Dr. Michael Rakotz, who's the Vice President of Health Outcomes with the American Medical Association. Mike's going to be sharing today on the importance of SMBP as a standard of care and some of the challenges that are factors in why it hasn't been scaled more broadly in the US. Next, we'll hear from Deborah McGrath, who is Director of Health Information Technology for the Health Federation of Philadelphia, which is an HCCN in Pennsylvania. Deb's going to share on the current state of SMBP, including technical challenges and successes operationalizing SMBP in a remote care environment. And then to wrap us up today, we'll be hearing from Dr. Tom Giannulli, who is the CMIO of the AMA's Integrated Health Model Initiative. And Tom's going to focus on the future state of SMBP, what that requires and what that could look like. So I'm actually going to transition to sharing my screen and orienting you to a new tool, which is called Mentimeter. Some of you may have used it in the past before. What I'm going to ask you to do is either open up a new tab on your computer, or even simpler is to pull out your smartphone. And what you're going to do is type in the URL you see at the top of the screen. So www.menti.com, and then you're going to type in that code that you see, which is at the top of the screen as well. So that's 7185534. What you should see then is a little dot that you can maneuver and tell us where you are from. So this is sort of a test exercise so that you can answer the poll question that we have next. And I'm just going to wait a moment. Hopefully you can navigate to that URL, type in the code there, and then answer the question.
Meg, look, oh, there goes, the code is now available. So the code for everybody is going to be 718558 and then 4. So 7185584.
All right, I see a dot. It looks like somebody figured it out. North Carolina is represented. Ohio's in the house. We've got Connecticut, California. It's like DC maybe. This is great. So we'll give this just another minute. I just wanted to make sure that you could navigate to the the website and type in the code, and that'll set you up for our next question. Very cool. Looks like we've got the Midwest represented. We've got Florida, Louisiana, Mississippi, Alabama. Looks like Chicago's in the house, Arizona. Very good. So let's just give this like another maybe 20 seconds and we'll transition. Pennsylvania, New Jersey, very good. Okay, well, thanks everybody. If you're already in Menti, then you don't have to do anything. You should just see the slide advance on your tab or on your smartphone. I see a bunch of votes coming in. Excellent. So now that we're done with our fun sort of where are you icebreaker, this is a serious question just to kind of set the landscape for who's in the audience today. So the question is, how would you describe your current use of self-measured blood pressure monitoring? And feel free to choose all that apply here. So you can select any of these 4 answers. We are using home blood pressure monitors for vital signs during virtual encounters. We're using them as part of a protocol for hypertension management. We are planning to use home blood pressure monitors in the near future, or we're not planning to use home blood pressure monitors. So I'll give this just a little bit more time. We've got 20 respondents, and I think we've got over 40 participants. So it looks like a lot of folks are planning to use home blood pressure monitors. So glad you're here today because I think we have a lot of useful information to share with you. All right. So great. Really appreciate your participation and your engagement. Mike, hopefully this sort of frames the audience for you so you know kind of where people are at. And I'm going to go ahead and move this over to you.
Sounds great. Thanks, Meg. Good morning, everybody. Thanks for attending today. I've got just a few minutes really to set up for Deb McGrath and Tom Giannulli for you. Some of the challenges around, well, first of all, defining what we mean by self-measured blood pressure monitoring, effective use of self-measured blood pressure monitoring and implementation, and some of the challenges. So let's get right into it and go to the next slide. So just very briefly, this is just to illustrate one of the reasons that we've got such an urgent need to prioritize blood pressure control in the United States. If you go back to 1999 to 2009, we had a substantial increase or rise in blood pressure control, going from about 32% to about 53%. Since that time, we plateaued for about 5 years there. And really since 2014, we've been going in the wrong direction. Now, really back to 2005, 2006 levels of blood pressure control, close to about 44%. So 44% of US adults with hypertension are currently at goal. Next slide. So for this reason, and many others, the Surgeon General's call to action came out recently for the prioritization of blood pressure control nationally, cultivating community supports for blood pressure control and optimizing patient care. These are the 3 goals and the underlying strategies that the Surgeon General has highlighted to prioritize blood pressure control. And if you take a look at the box on the right highlighted here, these are more of the tactics for healthcare professionals, and they're really divided into 3 buckets. The first, which is the several of the checklists here, really center around intensifying treatment. The second is using self-measured blood pressure monitoring with clinical support for patients with high blood pressure. And the third is using data and dashboards to identify gaps in care and trying to close those gaps in a team-based fashion. And those really, the framing of what the Surgeon General wants to do, and specifically in healthcare professionals to optimize care, I think this really sums it up nicely. But let's talk specifically on the next slide about what, let's get to what is self-measured blood pressure monitoring that's highlighted here. And SMBP, as I'm sure many of you know, I'll refer to self-measured blood pressure monitoring as SMBP from this point forward, refers to blood pressure measurements obtained by patients outside of the clinical setting. And this usually happens at home. Next slide. So let me briefly break down the benefits of self-measured blood pressure monitoring with clinical support, sometimes called co-interventions. These clinical support and co-interventions include web or phone-based support, patient education and training, individualized counseling, and titration of antihypertensive support or co-intervention. There's copious evidence to support that these increase the likelihood of treatment intensification, so lower therapeutic inertia, decrease therapeutic inertia by increasing intensification, increasing adherence to antihypertensive medications by patients, leads to clinically significant reductions in blood pressure, both systolic and diastolic blood pressure, and predicts cardiovascular risk independent and better than office blood pressure measurements alone. And I think this is the why we use SMBP, or why it's so strongly being recommended. Next slide. So I'm not going to go through all the details, but I will say that in 2017, the ACC/AHA guideline came out with very strong evidence, strongest level of evidence, 1A recommendations for using SMBP to confirm a diagnosis of hypertension, for guiding treatment and titration of medications after a diagnosis has been made, and for monitoring over time as a systematic strategy to improve blood pressure control, along with telemonitoring and team-based care. Next slide. So the effectiveness of SMBP for managing high blood pressure has been made very clear, that when used with clinical support or co-interventions, means reduction in systolic blood pressure of around 6.1 millimeters and improvement in blood pressure control. This is when compared to usual care. So it doesn't just mean that if you use SMBP in the management of hypertension, that you'll see a 6.1 millimeter drop in systolic blood pressure. You'll see a 6.1 millimeter greater drop in blood pressure than usual hypertension management without SMBP. And this is based on patient level data from systematic review and meta-analysis. So this tends to be what we see. It doesn't mean you can't see significantly more drops in blood pressure, but this on average is what's typical in addition to usual care hypertension management. And of course, this leads to an improvement of blood pressure control rates in a population when performed. Next slide. So let's talk very briefly about barriers to widespread adoption and why this isn't happening everywhere. There's patient perceived barriers, provider perceived barriers, and health system barriers that we're going to talk about briefly. And I think that the main barrier for patients really continues to be out-of-pocket costs for purchasing devices. And that is something that, of course, the solution for that would be coverage. And some of the other speakers are going to talk about that just a little bit, but how that barrier can be overcome is extremely important. We have to put a lot of effort there. Providers are concerned with not only the lack of reimbursement for device purchases, but the inaccuracy of devices. So device accuracy is really center stage here. We've got to have physicians and other providers trusting the measurements coming off of these devices so they're used. And there's a strong concern about the impact on staff time and provider workload. And what are the workflows? And I think very relevant today, the health system barriers include a lack of financial incentives for using SMBP that is perceived, a lack of systems to transmit and transfer SMBP data back to the health system, to providers, to the electronic health records so that they can be viewed and action be taken, and a lack of support for these very important intensive co-interventions that really improve blood pressure control. And you can see some of the potential solutions I have here on the right. I'm going to let my colleagues who are speaking today talk a little bit more about those solutions. Next slide. So in an effort to try to combat some of these challenges, the US BP validated device list, it has been up since April of 2020. This is a listing of validated blood pressure measurement devices, meaning they have been tested for clinical accuracy using internationally accepted BP validation protocols by independent experts. So this is really for the first time. What's important here is that whether you're a patient or a provider or a health system, you can go to the device listing and all of the devices listed have been tested for accuracy. This is an effort to increase awareness of which devices are accurate and can be used to lower blood pressure. Next slide. And also just wanted to briefly talk about from, overcoming the challenge of a lack of reimbursement for services, there are CPT codes now for using SMBP. They do require the use of validated devices. And again, this is something that our other speakers today will talk about. But just for your information, these CPT codes can be used for education and training as and the other, if you look to 2019, there was only one national controlling high blood pressure quality measure that actually allowed the use of self-measured blood pressure monitoring. And currently, we now see as we move into 2020 and 2021, all major national controlling high blood pressure quality measures are aligned and accept home blood pressures, some in different ways, but this is a really important transition and may help increase incentives for health systems to use SMBP. Next slide. And this will be really the final thing that I want to talk about. In 2015, 2016, this has to do with the survey question that you had today, where about a third responded that they were using SMBP in clinical practice. Representative samples of providers were questioned about whether or not they're using SMBP, and 97% of them, about 97% said that they were using SMBP. But in a recent JAMA Open study during the pandemic, they looked at what percentage of visits was a blood pressure or a blood pressure assessment, to be more precise, actually performed in primary care during those telemedicine visits. And the answer was less than 10% of the time. So while most providers say they're using SMBP, the reality is we're capturing that data less than 10% of the time. And I think this is really important and has exposed the fact that we really aren't capable of doing this yet at scale. And we need to figure this out quickly. Next slide. So just in summary, SMBP with clinical support's an effective strategy to improve blood pressure control. We have a lot of challenges that remain that Deb McGrath and Tom Giannulli are going to address today as far as adoption and widespread use. There are emerging solutions for using validated devices and relaying SMBP data back to clinical teams that have the potential to increase adoption and widespread use. And with that, I will turn it over to Deb McGrath.
Good morning. My name is Deb McGrath, and I am the Director of Health Information Technology for the Health Federation of Philadelphia. And I'm really thrilled at the opportunity to talk to you about this, about SMBP this morning. Just by way of background, I'm a nurse practitioner by training, and I moved into health information technology about 15 years ago. I'm currently in the process of implementing SMBP programs for about 600 patients at 7 different health centers in the Philadelphia area. And my goal today is to give you that perspective from the ground as we are embarking on this pretty interesting, I'll put it, implementation process. Next slide, please. So my goals today are to really talk about adopting data and workflow processes that align with the 5 rights, the right data or information in front of the right person at the right time in a format that they can consume, and the right channel, meaning the right software or system. But I'm going to kind of co-opt this a little bit and also talk about leading to the right outcome, which from my perspective is to improve intensification of therapy opportunities and to reduce therapeutic inertia. And I want to look at the third goal, because you'll see that I sort of hedged my bet there, starting this discussion to begin solving the technical and data flow issues. There are significant technical and significant data flow issues right now with this. I want to make sure we don't let the perfect get in the way of the good, but at the same time, I also don't want to sugarcoat that this is a little bit difficult to implement from a variety of perspectives. Next slide. So as many of you said that you were getting ready to do SMBP or to implement SMBP, and I want to caution you or ask you to think about some of the things that you should be considering as you're entering into this. So using self-reporting devices or Bluetooth enabled devices, that is the program that we're implementing. all of the devices that we are deploying are Bluetooth enabled, and there's also the ability to use mobile cell phone towers for some devices, and I'll talk about that in a minute. And then you have your regular electronic BP cuffs with memory that do require, number one, you lay eyes on it when you're working with the patient, which can be challenging, but number two, recognize that you may have some challenges around calculating average BP measurements. Then thinking about how will the home monitored blood pressure readings get to the provider for action? How are you going to enroll patients in this program? And how will patients be identified to be enrolled? And then finally, what considerations around configuration of the electronic medical record need to happen? In one case, well, in two cases, we're working on creating a place within the EHR where the average BP can be documented, as well as specifically called out as a home monitored blood pressure, so that we can use that for evaluation purposes. Next slide, please. So where are our successes? I talked about how we have been able to configure some to store and present SMBP values to the provider at the right time in the workflow, but right now, all of those are manually entered. We don't have a situation where the EHR is able to receive directly the home blood pressure values. We've also been successful in configuring some of the EHRs with order sets to allow for really an electronic documentation of structured data for referral, understanding the referral process of the patient to an SMBP program, and the ability to document treatment intensification. It's important to note that capturing treatment intensification episodes contemporaneously with encounters with the patient is challenging. So any of you who have had to produce encounter level data so that you can really understand what's happening at the level of the encounter probably understand where I'm coming from. And that's why we've created order sets. So we're trying to get the provider to tell us what they're doing at each of these visits. Some of the EHRs allow for the gathering of SMBP readings through the patient portal, and in some cases, after staff have reviewed the readings, can be committed to the EHR database. I do think it's very important that clinical eyes are on these readings before they're committed to the database, so that you don't run into issues of sort of noise going directly into your EHR. And then we've been able to leverage population health management systems to prioritize and track patients for SMBP programming. Next slide, please. So this slide really is putting the challenges in sort of 4 boxes. The Bluetooth technology, I want to talk about that for a minute. It's unreliable. It is often difficult to set up, and we're dealing with some significant digital literacy issues, both with patients and frankly with staff. So understanding how Bluetooth works, understanding what you do when it won't connect, what you do when it lets go of its connection. I have found that it's very device dependent. So depending on the particular mobile device that you're using, whether it's a tablet or a phone, and the actual monitor itself can often cause some real issues. Also, patients who are going to use Bluetooth technology have to have both internet and a device that can accommodate that. So Bluetooth connects it to the phone or device, obviously, and then you've got to connect to the internet in order to transmit it. So there are some devices out there, and I think there's more interest at the device manufacturer level in using cell phone networks to do the whole thing. So the device itself is connected to the cell phone networks and communicates values that way. And I think there's some real advantages to thinking about about those types of devices. The other thing about these situations where you're handing a Bluetooth-enabled device over and hoping that it will connect back to your EHR is that you've got an issue where the patient might share that device with a family member or friend. So this is where connecting Bluetooth, disconnecting Bluetooth really becomes important so that you're not getting somebody else's blood pressure readings in there, but at the same time very challenging because it's non-trivial to keep connecting and disconnecting the Bluetooth. So, you know, we've talked a lot about the limited capacities of EHR systems, and that definitely continues to be a challenge. Many of the systems are very, their design is very dependent on revenue and on reporting. So these blood pressure readings need to be considered applicable to both revenue and to reporting, and in some cases that's the reason for the limiting of those going in. The other limitation I'm finding is that there are partners who are working with the EHRs to move the blood pressure readings directly into the EHR. However, they require that they select the device, so you don't have any control over that device, and their business model is based on revenue sharing around the remote patient monitoring, which is not currently covered by the remote patient monitoring codes, excuse me, that are not currently covered by Medicaid. So that's very challenging. Those are for Medicare patients only. I've already talked a lot about the patients, and then there's the other challenge is the people challenge, which is just staffing, to have enough staffing to manage a program like this. Next slide, please. So where do we go from here? So I want to be sure that I say that, again, we don't want the perfect to get in the way of the good. We're embracing the concept of SMBP in our HCCN as a valuable tool to assist patients. We also, one weird thing that's happened, just as an FYI to the folks on this call, we've had guest networks that are too slow and aren't well resourced. So it's really difficult to enroll patients when you're on site, when you can't get them on a fast enough network to download everything that needs to be downloaded onto their phone and connect them to Bluetooth and get them going. So, you know, we're forging ahead. We have an active program. We're actively engaging and enrolling patients right now. It's going well in many cases, and the patients are actually really thrilled with the program, the ones that have committed to it. So, and with that, I'll turn it over to Meg. I believe my time is up.
Thank you, Deb. Really appreciate it. So we have a little Menti question, and I think I'm just going to give this a really, really quick turnaround. So if you want to enter a word or two, go to that menti.com site, use the code 7185584, and quickly enter just a phrase or a word or two about your biggest challenge around virtual hypertension management. We'll just take a quick minute to do this. Yes, I think you're certainly reiterating and reinforcing many of the themes that Deb just brought up. Staffing, reimbursement, cost, funding, billing, connectivity. So certainly, like I said, you know, a reflection of what Deb just shared in her experience. All right, we'll give this about 10 more seconds and I'm going to move on to allow Dr. Tom Giannulli to share with us. All right, Tom, you're up.
Thank you. My name is Dr. Thomas Giannulli. I am the CMIO for the Integrated Health Model Initiative at the AMA, and also the VP for Verify Health, which is an example of a solution for SMBP that we'll use today to kind of illustrate how we can address some of the challenges that were mentioned earlier. What a great job to all the speakers today. So we can go to the next slide. So we're going to start off with connectivity. The connectivity can be complicated if you're kind of band-aiding or kind of Frankensteining a bunch of components together, which is not unusual. There's a lot of pieces of this puzzle out in the market today. And to facilitate, making this simple and easy and reliable, we recommend using kind of a turnkey approach. And the turnkey approach offers several advantages. One is it directly connects to devices of any type that are consistent with a valid blood pressure device category. So BDL devices that are commonly used in the home, device you can pick up at your neighborhood CMS. And so by directly connecting them from Bluetooth into the mobile phone, or Bluetooth, or a device directly to cellular, you kind of eliminate kind of a middle player, which is in the market today, which is a cloud service provider for the device itself. And all offing into that system and getting patients to connect not only to the cell phone from the device, but the device cell phone into that cloud, and that cloud back into your infrastructure or into your EHR are two extra steps. So we suggest going direct, and an example of that is to basically have a mobile phone application that engages with the patient, offers them reminders, allows them to be educated, at the same time connects to several blood pressure cuff devices directly, either through the cell phone or maybe indirectly through a cellular connection. And so you kind of aggregate a bunch of devices into one point of connection. And that cell phone connection will then allow you to then connect to a single cloud instance where all the information is now normalized in a codified structured format using a FHIR standard that the AMA helped introduce for remote blood pressure. And now you have this cache of information which is securely held into one infrastructure. And then we can use that using the same solution to exchange with the EHR within your enterprise. And this could be done through several mechanisms, but typically the most standardized way to do this would be using FHIR or another type of interchange interface. And so even if your EHR instance does not have the data schema or the capacity to hold the structured information about the blood pressure measurement, we can hold it in a secure cloud environment and then feed it into the EHR when available, or feed it directly to the doctor, who we call a front-end integration. We'll show you in a minute, so that the provider can, within workflow, actually see those measurements in high fidelity, even though the EHR can't consume them directly today. Another important point is when we collect the information, we want to make sure we collect all the information, all the context. So we want to make sure we have the position of the patient, if they're in resting state, the cuff placement, cuff size, other factors that are really important to give this data measurement a high quality score. And so you can do that through, say, a mobile app that asks questions while you're doing the measurement or directly after the measurement was taken, and then send that all that information again back up to the cloud in a secured, structured way, in a normalized way that can then feed back into the EHR. It's important to note that we also support VDL, and I think it's important that all these systems do support the VDL, which is a validated device list that Dr. Raycott's mentioned earlier. So that not only is the data of high quality, but you know that the device that generated that data is of high quality. You can trust that information. So we actually embed that information, again, from the device all the way up into the cloud, so you can have this information available. It's also important that adherence compliance is maximized. It's one thing to set up the connectivity, but it's also another thing to make sure patients are activated and engaged. And one way to do that is to have a mobile app that helps drive that engagement, and it has multiple touch points to make sure patients are actively checking their measurements and responding to information fed back from the provider. Next slide, please. So this is an example of how, once that information is brought into a central area and then pushed into the EHR or pushed into a presentation that's within the EHR or within that workflow, the provider can see that information at a glance. And so in this example, you have a list of patients, and to the right, you have the measurements for the selected patient. And it's an ISO validated weekly blood pressure average calculation. and there's a quality score associated with that measurement. Now, if you look at the measurements, you'll see 3 hearts, and the 3 hearts that are dark indicates it's optimal quality measurement, which means that we've looked at the information around the context of the measurement that was taken. We looked at the device with VDL, and if the measurement frequency and periodicity was correct. And that, in those cases, we mark with a high quality score. So you have a lot of information coming in that can be weekly average, and what we like to do is tell you that these averages are really high quality and probably should be used to rely on making clinical decisions, while the other data may be something that you might want to consider a suspect. So this allows you to actually quickly decide which data is best for you to make clinical decisions, and then quickly make that decision. It's also important that once you have this information in hand, and to facilitate the workflow around billing and intervention or medication adjustment, that you mark to the system that you've seen this measurement, and you can go on to follow on steps which say, I want to change management or leave management alone. And that workflow is also enabled through the application, but it's important just to mention that getting the data to the provider in very quick 1 or 2 clicks, have it visible at a glance to determine the quality and the information at hand to make clinical decisions, and making those decisions and indicating to the system that you are making those decisions is really critical to a couple different workflows down the road. So next slide, please. All right, the next point I want to mention that is another challenge is operationalizing and scaling. And this has to do a lot of administrative overhead that is encompassed in the process of building an SMBP program. And so easy patient enrollment, either with loaner devices or patient-owned devices, is something that should be automated and simplified. And you can see on the screen here, there's a couple ways you can do that. You can also have inventory management built into the solution, so you can allow your practice to have a pool of devices and then give them to patients and track where those patients are. So when they come back into the pool, you can then redistribute them. Those are some of the key issues around administrative overhead that we've kind of built in and kind of thought about as you go through this process. Training and education is very important, and obviously we work with the AMA and AHA on target BP content, which we embed in the solution so that you can have the best education available for practitioners as well as patients. And you want to make sure that when you have a solution like this, you have a thought of a care team. So you have distributed tasks, provider, care manager, billing manager, all have separate, slightly different workflows within the solution. So you can then really deploy to a care team setting and scale that effort without additional complexity. Next slide. And so the final point is really around sustainability reporting. We looked at the challenge questionnaire that just popped up. There's a lot of questions around reimbursement, connectivity, billing, and reporting. So clearly, once the information has been captured from, say, a single hub device into a cloud, you have a large population of data that can then be used for reporting and analytics. And that can be just expressed as a dashboard, so you can get some really good information at a glance about compliance, patients that are ranked to be highly compliant versus patients that are lacking compliance. You can address those patients with a higher level of engagement. You can also look at the quality reporting performance based on your patient population or various populations. It's also important to allow this information to be funneled into the billing workflow. So the points we mentioned earlier about the CPT codes or quality reporting, those data elements are absolutely captured in a structured way, held and used for reporting, so you can then generate the needed output for billing against CPT or billing against quality criteria. And by leveraging a single cloud infrastructure versus having cloud infrastructure for multiple devices, you can do a query and very simply aggregate all that information. So once again, the connectivity and the architecture of how the information flows from a device into your enterprise is critical to secondary workflows, including reporting and financial reporting and billing. So with that, I want to conclude and open up for Q&A.
Thank you so much. So folks, my name is Liz again. If you joined in a little bit later or just need a quick refresher, the Q&A box is located in the lower right-hand side of your computer screen. It's available now. We still have a few more minutes until the event is completed, which I just see a question just popped in. But we'll go ahead and give you a moment to start typing in those questions. Simply type it in. Make sure you select to all panelists and just hit send. We do have time to answer your questions. At this time, I'm going to turn things over to Meg, who will be announcing those questions for us.
Super, thank you, Liz. So we do have a question that says, what options do you have for patients who do not have a smartphone? And this could be probably any one of the panelists that would like to answer.
I can take that, Meg. There's a couple of options. One is trying to find devices, although I haven't found any yet that have hit the validate list, that do not require a smartphone, but rather use embedded cell phone technology, so they hit the cell towers. It does require purchasing a monthly data plan for those, so that's challenging. We have another option where, at least in Philadelphia, Consumer Cellular has given us 100 phones to distribute to patients who do not have a device. And we're about to deploy those at one of the sites with the actual blood pressure device. So that they've been open to helping in that way. And I think the other one is to think about how you can use hotspots. And but again, it does require some support of a device.
Super, thank you, Deb. Anything to add to that, Mike or Tom?
Yeah, I think there's some work being done to look at SMS texting. How can you capture some information, obviously not directly from the device, but potentially through SMS, which would not require a smartphone, but a SMS-enabled phone. There's also an ability to do automated phone response, so you can call into a call center. You may ask some automated questions. You can enter blood pressure that way. These aren't very low friction processes, or they're not as simple as using a smartphone, but there are other alternatives to getting digital data from the patient at scale using alternative means.
Yeah, and I'll just jump in and say, to that point on SMS, it's widely used in the UK and has been very successful, even in studies published as recently as last week by Professor McManus from Oxford. So they have a more robust system. It would be great if we had that option as well and built some systems around SMS only, in addition to having Bluetooth enabled and Wi-Fi connected devices.
Do you think it's important to note here that for right now, unless you're visualizing the device, that isn't going to count for UDS reporting?
Yeah, I'm not sure if you're saying that to me, Deb, but I do think that's an important point for anybody who uses UDS to report, that currently the requirement to be numerator compliant is that the blood pressure needs to be digitally stored and transmitted directly to the provider, or use of a remote monitoring device. So I do think that's important, and that is a limitation. Hopefully, according to NCQA, they are hoping to try to change that in the next year so that patient-reported BPs will be allowed, but for the moment, they are not. So I think that is an important point for UDS.
Thanks.
Liz, I know we're at time. We do have one additional question. I don't know if you want to take that. We can take that offline.
Yeah, let's go ahead, because of the interest of time. Let's go ahead and answer that one question, then we'll go ahead and give closing announcements.
Okay, so it's a question about the ability to connect, let's see, to landlines. So let's see if I can find the question again. Shoot.
I got it, Meg. I've got it. When I used to work at the VA, they did have a method that involved machines connected to landlines. Is that an option? And that's coming from Andrea, I believe.
Yes. Any thoughts?
I'm not aware of it, but
yeah, the like the 1200 baud modem kind of connectivity through PLPs. I don't know if that's something that's you can scale with that approach, to be honest.
All right. Liz, I think it's back to you.
Yeah, awesome. Thank you so much. Of course, everybody knows that this is a 4-part series, and thank you so much again for attending part 1. We'll see you back March the 23rd. Of course, everybody has registered for all 4 sessions, so no need to worry about that. Of course, if you have any questions in the meantime, you can always feel free to reach out to us at clinicalevents@nac.com. With that being said, we want to thank you for attending. Thank you for being here with us. Again, this event was recorded and will be made for an on-demand recording or playback for you. Have a great day. We will see you next month. Thank you. Bye, everybody.